I guess we can go ahead and get started. Good morning, everyone. I'm Dr. Viet Nguyen. I'm a physician informaticist and a member of the HL7 board and the technical director for the HL7 Da Vinci project. Thank you for joining me today at this session where we're going to talk about FHIR and setting the stage for automation. So I'll be honest, I'm not an automation expert, but I think when we think about automation, there are a number of examples we can look at. Here are some pictures from the Ford Motor Company showing us how they were building cars in the early 1900s to the assembly lines that we've had over the last century, and then the modernization of automobile manufacturing using robotics. Something more familiar and probably to some of the folks on the call is, especially if you happen to work in retail back in the 80s and 90s, is how we did credit card processing. I think my first job was in retail, and I'm very familiar with a credit card device to imprint the credit card and write the charge amounts, and then collecting them every night, and then sending them off to the credit card company to get reimbursed sometime in the future. We moved along and did it then electronically with these terminals that we're still using. But when I recently took a vacation for 10 days, I actually only had to pull out a credit card like 3 times. And every other charge that I did, I used my contactless credit card on my Apple Watch. And when I did that, I also got a notification that the charge went through. So each of these examples show how automation has improved efficiency as well as exchange of information and made it more seamless. And I think we have lots of opportunities to do that in healthcare in order to kind of reduce that 30% number that we refer to all the time around fraud, waste, and abuse. Hopefully with improved interoperability and automation, we can improve in the exchange of data, the collection of data, the sharing of data, as well as reducing the burden for clinicians as well as administrative staff that support them. So there are lots of concepts around automation, and I pulled 3 of these from Gartner's glossary just to highlight some of the differences when we talk about automation. The first is business process automation, which is defined as automation of complex business processes and functions beyond conventional data manipulation, record keeping, and through the use of advanced technologies. One of the areas that we have been using automation in the most recent past is around robotic process automation. And similar to the robots in manufacturing, they're doing repetitive tasks such as identifying information, entering information into fields like a human would do, but in a more scripted fashion. And so that's being used today, and I'll refer to one of them in the example coming up. But really what we want to get to is more of a business process management approach to the process we do and implementing automation. And that's really a discipline in and of itself to discover, model, analyze, measure, improve, and optimize business processes. So what are the characteristics of processes that are amenable to automation? I know on the agenda here for this WEDI Summer Forum, you have a number of experts from various companies, so I won't delve deeply into this. You'll probably learn more from them. But really, in general, the ideal workflows are high volume workflows that have low variability in their processes, that are very repetitive, and today are very manual. The example of the credit card is a really good one, where you have to have a person taking information and entering it. Ideally, processes are standardized, so we know step 1, step 2, step 3 that we can define well. Tasks that are very data entry intensive. We look at, that's a huge part of what we do in healthcare, so there are lots of opportunities to improve that. And then data that's very, processes that are very data intensive, where it may be collected by one individual or one system, but need to go to another individual or another system in order to continue the workflow. And what we've realized in the interoperability space over the last few years, especially with FHIR, is that the work we do is not just about defining terminology or defining messaging payloads or data payloads, but the work that we do in delivering healthcare is workflow, and workflow interoperability has become more and more important. And the best example is, as a physician, I might write a prescription, but I don't dispense the prescription. And so I need to hand that next task in the medication prescribing, dispensing, administration process to another system, another individual. And being able to share the workflow processes and track them is an important aspect of our kind of next generation of applying interoperability via FHIR. There are lots of tools available for doing automation. Robotic process automation bots is a very common thing that is done today using screens. But on top of those bots that work kind of in a scripted way, organizations are adding additional technology like computer vision, where they can look at a screen and be able to tell where the data is on the screen to help direct the bot to where to find the data. This is particularly important in systems where you might have a virtual desktop where the individual looking at the data, or the bot, has no direct access to the data. They can only see the data on a screen. Traditionally, the bots have been following scripted algorithms. So find this piece of data, retrieve it, find another piece of data, retrieve it, enter it here. But as technology improves with computer vision and machine learning, these scripted algorithms are now moving to more dynamic interactions with data. So they could read a chart and take that data off the chart and then start to process that data instead of just having to find data, pulling single components of the screen or the chart. Also, like with FHIR, we're using more and more application programming interfaces. So taking data and feeding it to the next system down the line so that the automation process can continue. So with this talk, I wanted to highlight 3 areas that the work we're doing in DaVinci are good examples of utilizing FHIR for automation. So the 3 examples we're going to talk about are around risk adjustment, around the use of FHIR for attachments, and quality measure reporting. This work wouldn't be possible without the support and sponsorship of the HL7 and DaVinci sponsors and the community members. So I want to highlight, if you're not already familiar with DaVinci, if you've heard me speak before, you probably are. We're a collaborative formed under HL7, brought together by stakeholders in the health IT community, the providers, payers, EHR vendors, to identify important use cases and develop, implement, test FHIR implementation guides to improve interoperability. So up to today, we have about 16 use cases we've identified and have developed 13 implementation guides. We have 2 more that are in the works, and a number of our guides have been identified in final rules and proposed rules in federal regulation. So the first example I want to point out is risk adjustment. I recently had a conversation with a colleague who is with a large regional payer and asked like how they were using automation. And he described this important task that his payer group would have to do around risk adjustment. So for those unfamiliar with risk adjustment, it's that patients have 1 or more conditions that as a clinician, I want to know about and I want to take care of. And if the patient is new to me or receives care from multiple providers, I might not be aware of all those conditions. Additionally, payers are dependent on providers to identify, document, care for patients, and have accurate diagnosis and documentation to ensure that their risk-adjusted payments are received from their government managed care programs. So there's a mutually important relationship between the payers and providers with respect to identifying the patient's conditions that have risk-adjusted payments, and providers having that information and sharing that information with providers. So in the example I had in my conversation with my colleague was that their population health risk adjustment team had a list of patients that they needed to make sure that there was documentation. For larger healthcare organizations where they have relationships with, the team of nurses and analysts who gather this data may have access to the EHR, but would manually have to find the data to support the risk-adjusted payment. So they implemented a bot in order to try to find that information. But what they realized was their access to these EHRs was through Citrix, which allows you to see the information on the screen, or if you have to work with a healthcare provider person from their HIM group, the Health Information Management Group, you might only get to see what's on the screen. And the difficulty is that bots like structured data. So what this organization did was to add computer vision to look at a screen, identify and know what's on the screen, where information is, and essentially capture information straight from the screen, and then put it into their systems. And you might ask, well, why did they just integrate with the EHR and pull data? The response I got was that you can do that, but the challenge is that you have to still integrate with proprietary data models, and there is no uniform canonical model to aggregate data across multiple EHRs, and those working in interoperability are already familiar with those challenges. So here's the opportunity. And what we've done in DaVinci is identified an important use case called risk adjustment that we are in the midst of working on today. And what this process that the use case will support is the sharing of risk data between payers and providers. And this was a particularly good use case following the work that we've done that I've talked about in a little bit around quality measures, which is what providers and payers sharing information on both individual patients and lists of patients to identify mutually important information. So in this use case, a provider and a payer can share a list of patients that they both attribute to, and share that the conditions that are risk adjusted. So in this case, the provider would request from a payer this list of risk adjustment codes, and the payer could send back these list of patients along with both suspected conditions as well as confirmed conditions. So here's a mock-up of an example report that we've done as part of this use case and working with the community. And so what the FHIR component and the value that we can bring in with FHIR is that we use standard FHIR profiles. So in the US, we're using the US core, and we may add additional profiles if needed, but they would be derived from US core. So the value here is that the provider EHRs use FHIR, the payer systems would use FHIR, and we would communicate via FHIR the data around the patient, the provider, the conditions. We would use standard coding like the HCC coding, ICD, CPT, and we would use standardized FHIR APIs. So we've learned from our experience with the measure report, and we can do the request, and in the response, we would get information such as who is the patient, who is their primary care provider or their responsible provider, what plans they're on, as you can see on the left-hand side, which HCC codes and diagnoses have been identified by the payer for each of these conditions. And one of the benefits both to the patient and the payer is that payers often have very advanced analytics and can potentially identify diagnoses that they suspect the patient may have, but has not been documented or identified by the provider. So this is an important fine line that we've discussed in these calls, that the payer shouldn't be delivering healthcare or making medical diagnoses. So what they are providing is information around suspected diagnoses and any supporting information. So maybe they have a hemoglobin A1C or they have other data. And ultimately, it's the provider who takes this information, engages with the patient, cares for them based on these conditions, and generates the clinical documentation to support them. And with that, they can return that information both as claims data and other FHIR methods that I'll talk about in a little bit to then support the payer. So the benefit really here is these standard data models, and I'm going to repeat this theme: standard data models, standard APIs that can then be implemented in systems such as vendor systems, payer systems, and EHRs. Excuse me. The second example I want to bring up is around attachments. I know it's a huge topic for this community and for others in health IT, and we are eagerly awaiting some guidance from CMS around it. And we know that attachments are an important aspect of healthcare delivery, both the administrative side, such as claims, prior authorizations, but also in clinical care around referrals, care management, and we use it for any number of activities around auditing and workers' compensation. So the attachments in my mind are just collections of information, but there are challenges to the way attachments are done today. We're awaiting some standards, identified standards. There is currently no standard way for providers to identify specific information that payers are asking for. So they might send either too much information or too little information. The processes to gather the information is very manual. You have to look through the EHR, identify it, potentially print things out. You may have portals. Portals are certainly an improvement where you can submit or find out about data requests from payers, but for a provider and having to use multiple portals and managing these different portals is an administrative burden, and trying to manage the whole process ultimately can delay the delivery of care for the patient as you're waiting for things like authorizations. It can delay reimbursement as we are trying to find data, connect it with the right encounters and the right claims. And if the appropriate information is not sent because the request isn't communicated accurately or it's not readily available to send, it can result in denial of coverage, which is burdensome for both patients and providers. So with that, we have an opportunity to improve in the exchange of data and support the whole concept of attachments using FHIR. And so one example that we have this implementation guide called the Clinical Data Exchange, or CDEX guide. And the concept here in the first set of workflows that we've addressed are around post-payment review. So we know that providers are asked to submit data to support claims, whether through just to get the claim paid or through post-payment review for various auditing purposes. Today, as I've mentioned, you may use a portal or other approaches, but with the CDEX approach, a payer can identify the information that they need from the provider in a FHIR method. So let's say you're seeing you had a claim for diabetes care and you wanted to have the information around the hemoglobin A1C, any reports around consultations, say with an ophthalmologist, anything that can be represented and codified in FHIR, we can put into the request. And with that structured request, we use a number of FHIR technologies, particularly Task, the resource, to send that request to the provider system. The provider community wanted the opportunity to review these requests before fulfilling them. And we made that possible in this implementation guide. But in the situation where there is a high trust relationship between the payer and the provider system can respond automatically to that request based on the information in the request, those FHIR resources, those specific labs codified by Loink and others, and return them to the payer with no human intervention. So there's huge value here because, number one, we're using standardized data. So the onus now is on the payer to know what they want to ask for. Instead of just saying, give me everything, or the provider sending everything, you need to ask for specific condition information, documents, observations. But those conditions, documents, and observations are now codified. So you can say, give me all the data related to the diabetes condition, or give me the specific lab or specific document with a particular Loink code. And with the FHIR API, we can define the request, we can automate the request, and we can fulfill the request without human intervention. And the future opportunity that we're looking to advance the CDEX implementation guide is the opportunity to develop unsolicited attachments. So in a relationship where a provider may attach clinical data with a claim based on their contractual agreements, we could predefine a set of documents, labs, vital signs, conditions, medications, and have an EHR assemble all that information as a FHIR package and send that along to the payer. In an area where I think there's a huge opportunity is just the exchange of data from providers to other providers. I know we have techniques today with CDA and health information networks to share this information, but we can also use a FHIR approach where we could collect all the information necessary for, say, a endocrinology referral, where we can send across our encounter information around labs and clinical notes from a provider to a referring specialist so that they have it in advance. And in the ideal world, and my hope is in the future world, more and more EHRs could take that information and not only make it readable to the receiving provider, but actually write that into the patient's record. So now that data is computable for the specialist. And then when the patient is seen and a referral is completed or recommendations are made, that same information could be pushed back to the referring provider as opposed to not having it when the patient returns to me in a primary care visit. So there are huge opportunities here to exchange data in an automated way by assembling the data in a predefined fashion and then sending it with minimal human intervention. So the third category that I'd like to address is around quality measure reporting. We know that quality measure reporting is both important in terms of trying to get us to that learning health system, but that it's very challenging. There are a number of different quality measures, whether they be structural, outcome measures, process measures, patient experience measures, and even measures that are used to measure the performance of providers and provider organizations for reimbursement. So the ability for us to measure how we deliver healthcare is really important. And we have opportunities to develop better measures. And I think that that's something that all clinicians want. And we have opportunities to use measures that are already well-defined in structured data in order to move towards that learning health system and start to work on the more complex measures. But in order to do that, we have to overcome some of these challenges, like the data abstraction from, again, these proprietary data models, and get them into a form where they can be aggregated. Of course, today we have QRDA, which is a version of CDA that allows us to do quality measure reporting, but it requires work of individuals and often proprietary technology to take that EHR data, scour it for quality data, and then assemble these reports. And so there's a significant technical implementation challenge to doing the quality measure reporting. And as I hear from many of our Da Vinci members, they have teams of folks who work on this. And during particular seasons like the HEDIS season, everything takes a back seat to gathering the HEDIS data and checking it for quality and creating these reports. Also, knowing as a clinician what quality measures I'm responsible for is really challenging. Patients vary, and so their conditions vary, and what measures apply to them vary, and it may vary from payer to payer. So that's a challenge for clinicians. And because of just kind of the reporting cycle, there are missed opportunities where I could have, had I known, tried to address something for a patient, but I wasn't aware that I was responsible for a particular measure, or the patient didn't have a particular, had a condition that I wasn't aware of or didn't address in a timely way. So we want to be able to address that using a FHIR approach. And what we have here are really, I'm going to talk about two implementation guides and the component of one of them. And these are all around how we can exchange data for quality measures and use a member attribution list to do that. So these four guides, I've mentioned the clinical data exchange here is in ballot reconciliation. We hope to have it published later this summer, but the data exchange for quality measures is a guide that we use to, that we've created the framework around sharing quality measure data. Within that implementation guide, we added over the last year a method to do report gaps in care, to request and receive that between providers and payers, and a separate guide, but one that is foundational to these particular workflows, as well as value-based care in general, is a guide around sharing member attribution data between providers and payers, currently in a risk-based contract situation, but we're also working on the version 2 that supports CMS's data at point of care, as well as commercial fee-for-service, where a patient isn't attributed to a provider until they choose that provider and is seen by that provider. So we'll start with member attribution because that's more foundational. And the idea here is that in this version 1, a payer and a provider organization establish a risk-based contract, and within that contract defines a group of individual members that the provider is responsible for or is attributed to. So if you start at time 0, today those lists are often shared via Excel spreadsheets and have to be maintained and updated as members go in and out of different insurance plans. So that's very onerous because we need those lists in order to do population health and all the other activities around risk-based care. And so the method that we've defined is the ability for the payer provider to establish a version 1 of that list. And after that version 1 is established, the payer can then send that to the provider organization. And the provider organization can then use it for any number of other activities, population health and outreach, identifying which patients have been already seen in their system, patients who they might expect to see in their organization in the near future. But as time goes on, each month, that list is likely to change for the reasons I've mentioned, patients going in and out of plans. And so we need to be able to update that list. And so in this version 2 that we have, we're creating the API or defining the API to request that updated list. And with that updated list, we can see who's new or who may have dropped out of the attribution list. And then that list can then be updated for the provider and then used in their systems, as I've mentioned. In the data at point of care approach, it's similar in that the provider would send over a list of patients that they believe they can be attributable to because they have seen the patient. And the payer organization, and CMS is working on this now, can send back that list or acknowledge that list, that attribution list, and then allow the provider to request any clinical claims information that CMS has on that patient. So we could see a very similar pattern being used in the commercial healthcare setting. So with that attribution list, what's one useful thing we could do? Gaps in care is one that's really important to our Da Vinci community and has been a focus of work within HL7 for many years. And the idea here is that we want to leverage the ability to have that attribution list and request the gaps in care from a payer. And the value here is that the payer knows about the care being delivered that they pay for across multiple providers. And they already use systems to gather data for claims, potentially clinical data, and they're aware of the gaps in care for patients. And so the approach here with FHIR would be that a provider using either an individual member attribution list can request from the payer this gaps in care report. And that report would identify things that the payer believes are gaps. And that's important because if the gap is closed by another provider, say a patient gets their flu shot or a pneumococcal vaccination from a pharmacy, that's good for the provider to know. The other aspect is that when the gaps in care report is received by the provider, they can review that and identify information that the provider system may have on that patient and close the gap administratively or just with data. An example might be a patient who is new to a payer and they are 51 years old. If the payer has no clinical history on that patient, they would assume that the patient is due for a colon cancer screening. And so the first time a gap report is requested on that patient, colon cancer screening might be identified as a care gap. But that, let's say that patient had been seen by the same provider for 10 years, and in the year prior, the patient had had a colonoscopy, but it was just under a different plan. And so the provider would know that the gap had been closed, and so they can send the clinical information back to the payer to show that that gap was closed. And so that process of sharing now the quality measure data is the major part of the data exchange for quality measure implementation guide, where there are two methods of sharing quality data. A provider system can gather the required quality measure data and then send it to the payer. The question is, how would they know which patients, which measures apply to which patients? We have the ability in FHIR to define quality measures using FHIR and another technology called CQL, where you can define the inclusion-exclusion criteria, as well as the FHIR data that would be used to support the completion of that measure on a given patient. So using CQL and using FHIR, a FHIR-enabled system, whether it be a payer or provider, can scour the patient record, identify patients that match certain quality measures based on the quality measure inclusion-exclusion criteria, then gather the data or identify the data is missing for that particular measure, and then create a report. We call that a measure report. And the gaps in care report is a similar one that looks prospectively, whereas a measure report can be looking retrospectively. So did I complete certain measures over the past 6 months of my reporting period or not? With the same kind of CQL methodology and an engine that runs it, we can gather that data and package it up in FHIR, and then using a FHIR API, submit it to the payer. And this can all be done in the background. Alternatively, a payer can identify a measure they want information and do a request or collect measure data from a provider EHR or within their own system. And ultimately, we want to implement a subscribe feature when the subscription resource is mature in FHIR, where when quality measure data is being created, it's sent right away to the provider. The benefit here is that it allows us to use standard data again, patients, providers, conditions. For quality measures, we not only use the US core, but we also use the QI core, or quality information set of FHIR profiles. Again, well-structured information. We also use standardized coding, ICD, CPT. We use these APIs that allow us to do the request as well as the gathering of data using CQL and packaging the data and then submitting it. And really the goal here is to minimize the administrative burden of clinicians, so they're not having to put in information in a secondary system in order to gather quality measure data, and their staff doesn't have to scour the medical record to find quality measure data. It's all done via FHIR technology. And so this can be augmented by using clinical decision support and other technologies I'll talk about, so that the data that is created to support quality measures is the same data that is created in delivering care. So we're not asking the clinicians to do extra. We're asking them to do what they would want to do anyways in delivering high quality care. So I'm really very optimistic, and I know there's lots of support from CMS and NCQA and others to move us towards a digital quality measure ecosystem in the next 5 to 10 years. And I think that's very possible. It won't be all quality measures. It'll be the ones that we can define well in structured data, the ones that we can identify the data and record it in the EHR or other systems that are FHIR enabled. But over time, we want to see more and more data that's structured and available via FHIR and via FHIR data models. So how do we put this all together? And back to the larger theme is, how does FHIR enable automation? And I want to emphasize the word enabling automation, because the resources in and of themselves aren't automation. The APIs in and of themselves aren't automation. So we want to start with standard data, so that the data that's collected is the data that's generated as part of patient care. So we have these FHIR resources and profiles that I've mentioned. We have now FHIR operations. How do we gather that data, define our requests, define what we expect to be the inputs of these requests and the outputs of these requests. And by having these APIs, developers and companies can use these APIs as part of their applications and create that automation through their applications and orchestrate the set of APIs that they would use in the workflows. We also have Smart on FHIR. Smart on FHIR in itself isn't automation, but it certainly supports it, because it allows us to bring data that is already in the EHR, but help add value to it, visualize that data, gather that data on behalf of providers, something I didn't talk about around our burden reduction implementation guides. When a patient needs a prior authorization, payers define the list of information that they need in order to adjudicate that prior authorization. Today, that information is gathered manually and submitted to payers. By using FHIR, we can define that list of information, gather it on behalf of the provider using FHIR and FHIR data in the EHR, and display it to the provider so they can review it before submitting it. So there are opportunities to reduce that administrative data collection burden. We also have CDS hooks. CDS hooks, think of it as triggers within the workflow that allow us to provide information to the provider that is both clinical, like recommending a course of action, or can be administrative data, like helping the clinician know what the cost of services or medications may be. We use CDS hooks in particular with burden reduction because we can identify, based on a patient's coverage, we use CDS hooks to ask the payer if prior authorization is required. So we're minimizing that task, or automating the task of having to go to a portal to ask the question, or reading through coverage information to find whether or not an authorization is required. We have CQL, and again, CQL is this kind of scripting language that allows individuals to kind of define data that can be retrieved via FHIR and do things algorithmically with them. In the case of quality measures, if you want to define the inclusion criteria of a quality measure based on age, you can say, well, give me the patient resource, take out their date of birth and do a calculation on that date of birth based on today, and tell me if they meet the age criteria. So the power of CQL is this ability to do things that we could do with SQL in the relational database world, to do data gathering, define kind of a process of analyzing that data, and then using that to provide information that, say, a gap in care exists on a patient. And with CQL, those scripts can then be converted to native systems so that they can be implemented either via Java, rules, SQL, JavaScript. And so that allows us to have a shareable method to define these scripts and this automation. And how do we get there? I think a large part of how we get there is the standards that have been identified by ONC and some of the requirements defined through CMS. So here are a small list of FHIR-related standards that are in the 21st Century Cures Act final rule, which identifies FHIR version 4 as the standard. It identifies the use of Smart on FHIR, the application launch framework, so allowing systems to be able to support Smart on FHIR apps, using OpenID and Connect to identify patients and do cross-platform authorization. And then very importantly is the identification of content vocabulary standards. This is a little bit of an old slide. Version 1 was published last year, and version 2 was just released a couple of weeks ago. And by defining and continually updating as terminology matures, these vocabulary and data standards, we really coalesce on, let's say, the Rosetta Stone of terminology that we're going to use, so that we're all essentially using the same codes and terms that allows us to improve our interoperability. And of course, regulations through CMS have really spurred the adoption of FHIR, and through the Patient Access API, which many of you probably have worked on and are keeping up to date today, as well as upcoming requirements around payer data exchange and recommendations CMS has along with that, and just engaging the entire healthcare community. We've had the providers using FHIR for years now. We now have payers implementing FHIR through the requirements around the Patient Access API, and now ultimately the patients can better engage in their care by being able to use FHIR and be able to use FHIR-enabled applications to get their information that their providers have or their payers have. So my question for you all is your organization ready to leverage FHIR? Which is different than, is your organization using FHIR? You may be using FHIR already because of federal regulations and requirements for your plans, but really the question that I pose to you is, are you ready to utilize that data for other purposes, to improve the efficiency of your care delivery or the efficiency of your administrative processes in order to reduce the burden for patients and providers and to improve the care ultimately for the patients in our population. So with that, I probably have only about a minute to answer a question. So let me take a look there. Any questions?
Well, thank you, Viet. That was incredible. Action-packed as always with you. Too much data, I don't know, but an awful lot of great data. So quickly, in the couple of minutes we have here, Tim Kaya earlier basically talked a little bit about the idea of automation and how the key to automation is having the critical data. I think you've just talked quite a bit about how the level of structure, granularity, consistency, standardization of data within FHIR, thinking of FHIR as a data schema, is fundamental to creating that world that Tim's talking about. So have you heard any conversations now when you talk about, are we ready to use this FHIR data or make it, really leverage it beyond the mandates? Have you heard any conversation about how people are applying, things like AI and ML on top of this data with process tools and, process automation to be able to really go to the whole next level that Tim was kind of, shooting toward?
Yeah, I certainly, we're at the point with using FHIR data really algorithmically through things like CQL. So I think that's the first step, but we certainly have communities coalescing on how do we take the kind of NoSQL approach that FHIR data gives us and use it in machine learning. We certainly could extract that data and use traditional machine learning tools and put them into a relational database. But I really think that this is the new opportunity with FHIR, emerging opportunities where you can put all this information into a data lake and use machine learning tools, AI tools to gather inferences from the data. So taking and identifying patients at risk for certain conditions, or segmenting patients and finding patients of subpopulations so you can more effectively use the resources for population management. So I think there are lots of opportunities here for AI and machine learning, and those are relatively early days because folks are right now just trying to get their hands on the standard data.
Well, thank you very much. This has been an incredible session. Really appreciate your contributions, your ongoing contributions to WEDI, and your support for us. So with that, thank you to Viet. I want to take this opportunity to let people take a 30-minute break, rehydrate, refresh yourselves, eat whatever you need to do, roll your shoulders or roll your eyes, whichever. But we'll see you back at 12:45. Thank you very much.